All right, so just like for part one, part two, we're going to have the exact same learning objectives, but now we're going to focus on non-ST elevation acute coronary syndromes and not STEMI. And again, the same goals. We've tried to distill this down to those nuggets or key factoids and tried to avoid review of all the clinical trials. So some definitions. Peter touched on this in his earlier talk. We'll go over the early invasive strategy, which is rapidly risk stratifying patients with coronary angiography, the early invasive within 24 hours, and delayed invasive 25 to 72 hours. And then we'll also talk more about the ischemia-guided strategy. And remember, that really tries to avoid routine coronary angiography unless patients have refractory symptoms, hemodynamic instability, ischemia of concern on functional testing, or other clinical risks of an increase or high prognostic risk. So the plan in those patients would be to start with guideline-directed medical therapy and then try to evaluate for evidence of ischemia. So again, adapted from the ESC guidelines, the construct here, these patients are coming in with chest pain. The working diagnosis is an acute coronary syndrome, and we're going to focus on the right-hand side of this algorithm. So we're looking at our EKG, and then we're really using the troponin as the tiebreaker here to determine whether we're going to label these patients as a non-ST elevation acute coronary myocardial infarct or simply unstable angina. So if we see a typical rise and or fall of troponin, those patients will be labeled as a non-STEMI. So in non-STEMI, mortality is highest at the time of that hospitalization. It's often due to sudden death or development of a recurrent acute myocardial infarct. But that mortality risk is there even after that hospitalization. By 6 months, non-STEMI patients have the same or higher mortality than STEMI patients. And when you get to 12 months, if you look at big registries of patients with a non-STEMI, generally that risk of death, recurrent myocardial infarct, or instability exceeds 10%. So the pathogenesis of unstable angina or non-STEMI, the type 1 non-STEMI, we have the vulnerable plaque, so plaque erosion, plaque fissuring, plaque rupture leading to thrombosis. On the other end of the spectrum, we have those extrinsic conditions that can cause maybe symptoms or maybe simply EKG changes and a rise in troponin. And it relates to an imbalance of myocardial oxygen demand and supply. So tachycardia, hypotension, hypertension, anemia, all these things resulted in that shift of myocardial oxygen and demand supply. So we can have dynamic obstruction. That can be coronary vasospasm, possibly cocaine-induced vasospasm. We can have severe narrowing, so someone with fixed obstructive coronary artery disease that maybe has one of those inciting triggers that leads to myonecrosis, and then spontaneous coronary artery dissection. So Peter touched on risk stratification. The 3 most commonly used risk scores, TIMI, GRACE, and PURSUIT, all demonstrate good predictive accuracy. We've transitioned now, most of the time we're using the GRACE score when utilized, and to recall that GRACE score of 140 or higher is what we're looking for to identify higher risk patients that may benefit from early revascularization. Now, a word on shock. Obviously, these patients are going to be at our highest risk. 5% of patients with non-STEMI develop shock. Now, when you contrast those patients compared to STEMI patients that develop shock, non-STEMI patients generally are older. They have more medical comorbidities. They develop shock later in the course as opposed to right away. And they often have more extensive coronary artery disease. Of patients presenting with cardiogenic shock, 1 in 5 presented as a non-STEMI. And for those patients with refractory shock, there's a very high mortality rate. So let's move on to the strategies. So we have someone coming in with unstable angina or non-STEMI, they're admitted, and we're going to make the decision should they go for an early invasive strategy or the ischemia-guided strategy. So we'll touch on the invasive strategy first. Those patients with refractory angina, hemodynamic instability, or that are stable but have a number of risk factors of increased risk will generally do an invasive strategy. And some of those risk factors are a high risk score, so a high GRACE score, a high TIMI score. As Dr. Nishimura said earlier, the decision is easy when someone comes in with a positive troponin, EKG changes, those patients with left ventricular systolic dysfunction or prior coronary artery revascularization. Generally, all of these patients, we're going to be pursuing that invasive strategy. Now, within that invasive strategy, the next step we often decide is how early should those patients go to coronary angiography. So we have the immediate invasive, generally defined as within 2 hours, early invasive within 24 hours, and then the delayed invasive approach. And common sense, those immediate invasive patients are the patients that are really sick. So refractory angina, angina that's recurrent despite therapy, someone with acute heart failure, acute MR that you think is a complication related to the myocardial infarct, hemodynamics instability, or sustained ventricular arrhythmias. Those patients generally go right away. Early invasive, GRACE greater than 140, those patients that we have a temporal change in the troponin and or new ST segment depression. So what about the ischemia-guided strategy? Again, these are patients that we think ACS is unlikely, despite them having been admitted to the hospital. We think ACS is unlikely, or maybe they have extensive comorbidities and we really don't want to pursue an invasive approach in those patients, or those patients that we deem are low risk. Maybe they do have ACS, but overall their risk is low, and perhaps that's because we know they have normal LV function. Maybe they've already had their risk stratification study. They're hemodynamically stable now. They're on guideline-directed medical therapy, and your functional study was either normal or shows a low burden of myocardial ischemia, or those patients who up front have a low risk score. Those patients often have an ischemia-guided strategy. We talked a little bit about this earlier in the preceding talks. Just a mention regarding women. Women who have a non-STEMI generally present later than men. Their symptoms are more atypical. They often are inappropriately discharged from the emergency department with a non-ST elevation acute coronary syndrome. And the other issue with women is that both the acute in-hospital risks associated with non-STEMI and the longer-term risks after a non-STEMI are higher in women than compared to men. So women with a positive biomarker have a significant benefit from an invasive strategy that's highlighted in the guidelines, and also no benefit was seen with an initial invasive strategy in women with negative biomarkers. So we'll talk a little bit about early hospital care. Rather than repeat those same flow diagrams we showed in the STEMI talk, it's easy to remember all routine medical therapies that apply in STEMI will apply in non-ST elevation acute coronary syndrome, and I'll highlight just a few. So oxygen, morphine as needed, nitrates as needed, beta blockers, calcium channel blockers if they're intolerant of beta blockers, and then our inhibitors of the renin angiotensin aldosterone system will be utilized, and I'll have another slide on that. We'll go over that. Balloon pump as needed. And then to remember, intravenous beta blockers used with caution. Intravenous ACE inhibitors are rarely used now, and again, used with caution. Most of the time we want to avoid our immediate release dihydropyridines unless someone is adequately beta blocked, and then we want to stop all of our non-steroidal anti-inflammatory agents, excluding aspirin. So in those patients that we know their left ventricular systolic function, we look at patients with a left ventricular ejection fraction less than 40%. All of them should be on a beta blocker, and all of them should be on an ACE inhibitor or an angiotensin receptor blocker unless there's a contraindication. If they have an ejection fraction less than 40% and diabetes or heart failure, remember that's when you want to add your aldosterone antagonist, and generally the earlier the better. So We'll move to a question as the transition. What is the correct antiplatelet and anticoagulant regimen in a non-STEMI patient treated with an ischemia-guided strategy? Aspirin, prasugrel, unfractionated heparin, aspirin ticagrelor, unfractionated heparin, aspirin bivalirudin and tirofiban, aspirin clopidogrel, and abciximab.
Okay. Okay, very good. So I'll be continuing here from Wells. So again, we're going to be focusing on the non-ST segment elevation acute coronary syndromes. In terms of the medical therapy, Wells touched upon the anti-ischemic and analgesic therapies and heart failure therapies. I'll be focusing on antiplatelet and anticoagulant therapies. So in acute coronary syndrome, we've learnt in the prior lectures that antithrombotic therapy is essential. And it's essential to modify the disease process as well as its progression. Through trial data and decades of experience, combination of aspirin, an anticoagulant, and an additional antiplatelet agent represents the most effective strategy in contemporary practice. The intensity of therapy is tailored to individual risk. And that's the risk of ischemic events on the one hand and bleeding risk on the other. So if we think about antiplatelet therapy first, we have the choice of oral agents, and these include aspirin on the one hand and the P2Y12 inhibitors on the other. The P2Y12 inhibitors include clopidogrel, prasugrel, and ticagrelor. Intravenous antiplatelet agents include the GP inhibitors, and this includes abciximab, tirofiban, and eptifibatide. For completion's sake, I will mention that another IV antiplatelet agent in the P2Y12 inhibitor class is cangrelor, and we'll talk a little bit more about that in the Q&A session. Another important caveat, that in those patients now in the era of intense dual antiplatelet therapy who have a history of GI bleeding, we need to make sure that we protect them with proton pump inhibitors. Aspirin, as we've already learnt, is integral as part of the therapy, and it again should be administered as soon as possible upon presentation. It should also be continued indefinitely. A point about abciximab. Now, this is testable and it's definitely in the guidelines, and straightforward, do not use or administer if PCI is not planned, so it's a class 3 indication. To provide context for this rationale, let's consider two important trials. In the CAPTURE trial, abciximab was tested against placebo, and in that trial, abciximab was provided within 20 to 24 hours before the procedure and continued for an hour post-procedure, and was associated with significant improvement in the rate of death, MI, or the need for urgent target vessel revascularization. Let's now consider another trial, the GUSTO-4 ACS trial. In this trial, they enrolled patients in whom early revascularization was not planned. In this trial, early revascularization was defined as revascularization within 48 hours. For unclear reasons, in those patients in the GUSTO-4 ACS trial who were administered abciximab upstream, there was an increase in ischemic events. It is for this reason that if you do not have a plan to pursue PCI early, then abciximab specifically is contraindicated. Now let's take our individual with a non-ST ACS in which we're considering an initial ischemia-guided strategy. We've started aspirin, and they will benefit from the addition of a second antiplatelet agent. And if in this situation, we have the choice between clopidogrel or ticagrelor. And this should be added to aspirin and anticoagulant therapy as soon as possible after admission. This should also be continued for at least 1 month and ideally up to 1 year. In our patient who's presenting, and we've decided on an initial ischemia-guided strategy, who has recurrent ischemia, and they're already on aspirin, a P2Y12 inhibitor, and anticoagulant therapy, it is then reasonable to consider the addition of a GP2B 3A antagonist before diagnostic angiography. Now, in this situation, again, we don't have planned PCI, eptifibatide and tirofiban are the only options. We would not consider abciximab. So again, for our patient with NST-ACS, and we're considering antiplatelet therapy, if we decided on an ischemia-guided approach, oral agents include aspirin and a P2Y12 inhibitor. Of those, the choice will be between clopidogrel and ticagrelor. If our patient continues to have recurrent ischemia, we can up the ante with the addition of a GP inhibitor. And the choices include eptifibatide or tirofiban. Let's now consider the situation when we're going to opt for an initial early invasive strategy. Again, antiplatelet therapy in addition to aspirin should be initiated. Now, if this is initiated before diagnostic angiography, we can use either clopidogrel or ticagrelor. If it's done at the time of diagnostic angiography, then we have the choice between clopidogrel, ticagrelor, or prasugrel. Now, in this setting, this brings up the question of pre-treatment with ADP antagonist or P2Y12 inhibitor. The data is limited when it applies to contemporary practice. However, it does exist. Pre-treatment with clopidogrel is supported by data from the PCI Cure and Credo trials, where it demonstrated a 30% reduction in the primary endpoint. Pre-treatment with ticagrelor is safe based upon the data from Plato and Atlantic trials. Pre-treatment with prasugrel was not explored in the Triton TIMI 38 trial. However, it was assessed in the ACOAST trial, and it did not improve the primary efficacy endpoint, and in fact was associated with a 3-fold increase in non-CABG-related bleeding and a 6-fold increase in life-threatening bleeding. For this reason, we do not initiate prasugrel before the diagnostic coronary angiogram. A caveat, prasugrel pretreatment in the setting of STEMI has still not been specifically explored. Again, in the setting of an initial early invasive strategy, a GP2B3A inhibitor may be selected for high-risk patients. In this situation, if we're going towards an early invasive strategy, abciximab now becomes an option, in addition to eptifibatide or tirofiban. It's class 1 if our patient has not adequately been pretreated with a P2Y12 inhibitor, and it's class 2A if the patient has already received such therapy. So we'll take our patient and let's consider the antiplatelet therapy. We're going for an initial invasive strategy. Again, we have aspirin. We have to add a second agent. We can add either clopidogrel or ticagrelor before angiography. Prasugrel becomes an option after the coronary anatomy is delineated. In a high-risk patient, we can add a GP inhibitor. In this instance, we have the choice between abciximab, tirofiban, and eptifibatide. Anticoagulation is also important in the treatment of NST-ACS, and it should be provided as soon as possible after presentation. So for our patient who's presenting with ACS and we're considering anticoagulant therapy and we're going towards an ischemia-guided strategy, the options are unfractionated heparin, enoxaparin, and fondaparinux. In this instance, fondaparinux may have an advantage, especially if our patient is considered a high bleeding risk. If we're going to consider the early invasive strategy, the options include enoxaparin, unfractionated heparin, bivalirudin, and fondaparinux should be, again, a concern because of the catheter-related thrombosis. So let's consider the reperfusion strategies. In our patient who's presenting with NST ACS, if we've considered a PCI as the reperfusion strategy, we should continue aspirin, we should continue the P2Y12 inhibitor. Prasugrel is an option after diagnostic angiography. It's reasonable to administer a GP inhibitor, either abciximab, eptifibatide, or tirofiban, if it had not been started before diagnostic angiography, especially in our high-risk patients. That's defined by troponin positivity or other clinical markers. If they've undergone PCI, it's okay to discontinue the anticoagulant therapy after PCI for uncomplicated cases. In our patient in which we pursue coronary artery bypass graft surgery, again, we continue aspirin. We try to discontinue the ADP antagonist 5 to 7 days before elective CABG. Again, more urgent surgery may be performed by experienced surgeons if the incremental bleeding risk is acceptable. Again, if you recall, we discussed that the CRUSADE registry, where clopidogrel was the ADP antagonist, indeed, there is increased bleeding associated with the surgery, requiring greater than 4 units of transfusion. However, there was no change in mortality, and the benefit by early revascularization was then reaped. Again, discontinue the GP inhibitors at least 4 hours before CABG. In terms of anticoagulation, we can continue unfractionated heparin safely, and we discontinue all the other agents, and we dose with unfractionated heparin. As Peter had mentioned in his talk on reperfusion, IV fibrinolytic therapy is not indicated in patients with non-ST elevation MI. As you recall, the administration of a fibrinolytic agent is associated with a prothrombotic milieu with increased thrombin generation systemically, and that's an important caveat. If this is administered to a patient with a non-occlusive ACS, it can transform that non-occlusive ACS to an occlusive ACS, so it can cause harm. So, if you have a patient who's low risk and somehow we've determined no PCI, we would continue dual antiplatelet therapy, ideally for a year. We would continue unfractionated heparin for 48 hours, or enoxaparin or fondaparinux for the duration of the hospitalization. If we go with PCI, again, they'll require dual antiplatelet therapy. Consider GP inhibitors for high-risk patients, and discontinue anticoagulation after PCI after an uncomplicated case. If CABG is the revascularization strategy, we continue unfractionated heparin, and we discontinue the other anticoagulant agents if they were already started, and redose with unfractionated heparin. If it's urgent CABG, you go straight to surgery, again, understanding the bleeding risks associated with that strategy. So we've sort of done a bit of a whirlwind, and I think this is a good opportunity to bring everything together. So a patient who has unstable angina or non-ST segment elevation myocardial infarction, they're all going to be admitted to hospital. When they admit to hospital, the first thing that happens, is the history and physical examination, which is part of the risk stratification process. Then there are 3 issues to consider. First, therapies that they all get, and that's the routine medical therapies. We want to treat ischemia, so if your patient is a candidate for oxygen therapy, nitrates, beta blockers, or calcium channel blockers. We want to treat the heart failure, so modulate the disease. So inhibitors of the renin-angiotensin-aldosterone system, ACE inhibitors, ARBs, beta blockers, and aldosterone antagonists. We then need to make a decision in terms of which strategy we're going to use. If we're going to go towards an ischemia-guided strategy, we need to anticoagulate, and the options include enoxaparin, unfractionated heparin, and fondaparinux. Fondaparinux may have an advantage in those who are at increased bleeding risk. We need to choose antiplatelet agents. We need aspirin. We need to add a second agent. That's a ADP antagonist. And the option is going to be clopidogrel and ticagrelor. There is an option of the addition of a GP inhibitor. In this setting, where we're not planning an invasive PCI, The two options are eptifibatide and tirofiban. Note, if you provide abciximab at this stage, there's risk of harm. If we go down the line of an initial invasive strategy, again, we have to provide anticoagulation. The options include enoxaparin, unfractionated heparin, fondaparinux, and bivalirudin. You cannot use fondaparinux as the sole anticoagulant because of the risk of catheter-associated thrombosis. We need to choose our antiplatelet agents. Aspirin, then a second agent. Before angiography, the only two options are clopidogrel and ticagrelor. If we've defined the coronary anatomy, prasugrel then becomes an option. GP inhibitor, again, eptifibatide and tirofiban. Again, if we're going for PCI within 24 hours, abciximab is an alternate option. So this is a flow chart. It sort of puts everything there for you. Hopefully you'll be able to walk through that. In terms of board preparation, this is how I learned. What I would suggest is you go and try to make a chart that fits best for your paradigm of thinking that puts all of this together. Here are some board pearls that combines what we talked about in this lecture and the last. First, regarding fibrinolytic therapy. It's indicated for STEMI with greater than 1 20-minute delay from first medical contact to primary PCI. You avoid ticagrelor and prasugrel on presentation. This has not been tested in the setting of lytic agents. Clopidogrel dosing, it's 300 milligrams if your patient is yet less than 75 years of age. If your patient is older, we do not provide a load of clopidogrel. You just give them a 75 milligram dose. Fibrinolytic therapy is contraindicated in non-ST segment elevation acute coronary syndrome. Prasugrel, avoid in those patients who have a prior CVA, who are older than 75, or who are low weight. Ticagrelor, ensure that the aspirin dose does not exceed 100 milligrams. For all ACS, we want DAPT to continue for ideally for 1 year. Remember, fondaparinux is associated with catheter-related thrombus formation. Again, these are the clinical guidelines. Now, typically, traditionally in these last 2 days you've seen we do questions. What I've done is I've considered the guidelines and I've also considered some of the issues that have been the nidus of consternation and frustration and how best to deal with them. So I've put together 10 frequently asked questions in ACS. Some of them have already been brought up in the last Q&A, so we'll touch on those briefly. And I hope that this is useful for you in your clinical practice. So, number 1, how do I choose between PCI and CABG as a revascularization strategy in acute coronary syndrome? So, let's go back to basics. What are we worried about in ACS? We're worried about sudden cardiac death, we're worried about recurrent ACS, and we're worried about the sequelae of chronic left ventricular dysfunction. These are all associated with increased morbidity and mortality, and we've come to learn that coronary revascularization can mitigate these deleterious effects. Now, we've learned that in STEMI, less than 1% of our presenters will be rushed to CABG. So really, we're thinking about PCI versus CABG in our patient presenting with non-ST segment elevation ACS. And the role for angiography is to confirm the diagnosis, guide subsequent antithrombotic treatments, identify culprit lesions, stratify long and short-term risk, and most importantly, to assess the suitability for revascularization. And this will determine the choice between PCI, CABG, or medical therapy. So if we looked at our circulation, and if we had lesions as delineated here, single vessel disease or two vessel disease, that does not include proximal LAD disease, basically it's dealer's choice. Okay, we would go optimally with PCI. If you look at the scenario with single vessel proximal LAD disease or two vessel disease including proximal LAD disease, again, you could go with either CABG or PCI. Of course, in all cases, we take into account other comorbidities, LV function, history of diabetes, and surgical risk. Here is where things get a little bit complicated, and that's with left main disease and triple vessel disease. Dr. Rihal had mentioned the syntax score. It's a score that looks at the nature of the angiographic lesions, and it's multifaceted. And this is a sort of a guideline in terms of what the coronary anatomy and what you should be thinking about in terms of revascularization. If the syntax score is less than 22, you can consider either CABG or PCI. With a syntax score that's starting to creep up between 23 and 32, we'd prefer CABG, but PCI is still an option. When your syntax score is really high, we really need to go towards CABG. Again, other factors in the clinical profile, including left ventricular function, history of diabetes, and surgical risks, need to be weighed into the decision-making strategy. With triple vessel disease, we can take the similar approach. And again, really it's only with a very low syntax score where you can consider both CABG and PCI. In the other settings, really we'd want to go ahead with a surgical complete revascularization strategy. Question 2, what is the optimal duration of dual antiplatelet therapy? So systemic upregulation of thrombotic and inflammatory mediators leads to what I would consider as the vulnerable blood. And then upregulation of local mediators and biological stimuli leads to, in the disrupted plaque, leads to the vulnerable plaque. These two issues interact, and it supports the use of high-intensity antithrombotic therapy. On the one hand, we want to really drive down ischemic events, but on the other hand, with this intense therapy, we are exposing our patients to increased risk of major bleeding. And how do we balance these two? With antiplatelet therapy and duration, to decrease ischemic events, maybe increasing their duration could further decrease ischemic events. But most certainly, in order to decrease bleeding events, we would want to decrease the duration. Now, the DAPT score was derived from the DAPT study. It took into account several clinical and angiographic parameters, and it tries to help us navigate this challenging area. Using the DAPT score, one would suggest that if it's equal or greater than 2, you could consider an increased duration of DAPT therapy, but you have to weigh the bleeding risk. Now, what's the benefit? Really, with the prolonged therapy, you're looking at a decrease in ischemic events by 1 to 3% at the cost of bleeding events that can occur in 1%. If your DAPT score is less than 2, I think the decision-making is a little bit easier because there's increased bleeding risk with no change in downstream ischemic events. In terms of DAPT for ACS, we have a large body of trial data, including CURE, PLATO, Triton TIMI 38, and we want to treat our patients with ACS regardless of the mechanism of reperfusion with DAPT for at least 12 months if possible. Now, if they're ACS post-PCI with a high bleeding risk, you can consider discontinuing that ADP antagonist after 6 months. So, what are the preferred P2Y12 inhibitors? Prasugrel and ticagrelor are preferred for the initial treatment of patients with ACS undergoing invasive management, and this is based on the trials that we have discussed. Ticagrelor is preferred over clopidogrel in patients undergoing non-invasive management of non-STE ACS. However, as we all know, in our practice, clopidogrel remains the therapy of choice for STEMI patients who undergo fibrinolysis, for patients with MI who require triple antithrombotic therapy, in whom the use of prasugrel and ticagrelor is not recommended because of the increased bleeding risk, and frankly, because it's not been studied in that scenario. Financial considerations is a big consideration, and if there's a medical contraindication to prasugrel or ticagrelor. So what is the issue regarding clopidogrel and proton pump inhibitors? The data would suggest there's a signal of harm with certain proton pump inhibitors. It does not prove biologic causality. The guidelines suggest to avoid co-administration of drugs that are strong or moderate inhibitors of the CYP2C19 gene. A signal of harm, as I mentioned, with co-administration of omeprazole and clopidogrel was observed. Pantoprazole and esomeprazole have less effect on the pharmacologic activity of clopidogrel than does omeprazole. Dexlansoprazole and lansoprazole have marginal effects on clopidogrel metabolism, and for these reasons, they would be the preferred agents, and that's the practice at our institution. When should I consider platelet function testing or genotyping? Okay. So in terms of platelet function testing, I think there is consensus that high on-treatment platelet reactivity, okay, so they're on an antiplatelet agent and they still have high platelet reactivity, is a major risk factor for post-PCI ischemic events. In the ADAPT DES trial, 50% of the 30-day post-PCI stent thrombosis was attributable to high platelet reactivity. High platelet reactivity was also independently correlated with a 1-year definite and/or probable stent thrombosis and MI in that trial. In the Trilogy ACS trial, which included patients with both clopidogrel and prasugrel, this finding was not confirmed. So if we distill the evidence, the use of platelet function information to stratify risk and inform treatment decisions as a routine approach remains to be proven efficacious. Evidence does exist to recommend genotyping and phenotyping only in high-risk PCI patients and especially when an unexpected event occurs after an ACS, for example, presentation with stent thrombosis on therapy. So what is the role of cangrelor in ACS? Cangrelor is under the umbrella of the ADP antagonists. It's an ATP analog. It is administered intravenously, and it was tested in the Champion group of trials and subsequently in a meta-analysis of those trials. Distilled from those trials, cangrelor may be useful to guarantee platelet inhibition in acute coronary syndrome where ADP antagonist loading is inadequate or cannot be administered. Now, we're limited here or hindered here by the availability and cost of this medicine. We have not used that in our routine ACS protocols. How do I change from one P2Y12 inhibitor to another? So we're going to take this one at a time. So let's consider first clopidogrel to ticagrelor. There is, in fact, a good body of data to support the strategy. Nearly half of the patients enrolled in the Plato trial were actually switched. And in that trial, they were given 180 milligrams of ticagrelor loading dose, irrespective of the last dose of clopidogrel. So based on these data, this would be the preferred way of changing from clopidogrel to ticagrelor. What about clopidogrel to prasugrel? Unfortunately, clopidogrel to prasugrel switching was not explored in the Triton TIMI 38 trial. However, surrogate data from small pharmacodynamic studies have shown that patients pre-treated with clopidogrel can switch to prasugrel, and this leads to an enhanced platelet inhibition. And in those small pharmacodynamic studies, the patients were loaded with 60 milligrams of prasugrel, irrespective of the timing or the dose of clopidogrel. What about prasugrel or ticagrelor to clopidogrel? This occurs actually very much more commonly than the earlier two scenarios, and that's really because of the cost and it's a lot easier for patients to be compliant. Again, not too much data or evidence to suggest a specific approach. We have given 600 milligrams of clopidogrel loading dose, regardless of the timing and the last dose of prasugrel or ticagrelor. What about prasugrel to ticagrelor and vice versa. This actually occurs very rarely, about 2 to 4% of patients. Again, clinical data is lacking, and pharmacodynamic studies are also limited. Anecdotally, the administration of a loading dose is preferred when switching between these two agents. What about cangrelor and the oral P2Y12 inhibitors? If the second agent is clopidogrel or prasugrel, you can administer these agents immediately after the discontinuation of IV cangrelor. With ticagrelor, the ticagrelor can be administered either before, during, or after cangrelor infusion, and this is related to the pharmacodynamic interactions of these agents. What about oral P2Y inhibitor and cangrelor? And really that setting is when you don't know how well loaded those patients have been. And essentially you can start cangrelor at any time. Question number 8. How do I manage post-ACS antithrombotic therapies for elective non-cardiac surgery? Now, Mike talked about this in the stable ischemic heart disease setting. The risk of stent thrombosis is increased if the stent was placed in the setting of an acute coronary syndrome and secondary to the surgery itself, which provides a pro-inflammatory state. For elective non-cardiac surgery, and if you have a bare metal stent, we want to try to delay surgery for at least 30 days. If it's a drug-eluting stent, we want to delay surgery for at least 6 months. However, if the delay of surgery, if the surgery of the risk incurred by the surgery is greater than the risk of stent thrombosis, you could consider a 3-month duration of DAPT. Now again, this is all, there's no data to support this exactly. What about long-term anticoagulation? Is there a role for long-term anticoagulation to diminish ischemic risk? We touched briefly in the Q&A session of the stable coronary artery disease about rivaroxaban. What does the data tell us? ACS is a systemic disease. It is associated with a pro-inflammatory state, and even after we treat our patient in the index hospitalization, their highest risk for recurrent ACS is within the first 6 months. Basic science studies have demonstrated increased thrombin generation during the first 3 to 6 months after ACS. Therefore, there has been premise or hypothesis of anticoagulation mitigating ischemic risk in this setting. Warfarin has been studied. In this setting, there was benefit at the cost of increased bleeding, and these studies were all predating the use of the more potent antiplatelet agents like clopidogrel, ticagrelor, and prasugrel. Other agents have also been studied, the DOACs. Of those, rivaroxaban had the most benefit, but again, comes at the cost of increased bleeding. For initial ACS presentation, aspirin and an ADP antagonist should be initiated. There is currently no role for adding oral anticoagulation to improve secondary prevention. In some countries outside the USA, in patients managed with aspirin and clopidogrel, the addition of low-dose rivaroxaban is an option to reduce the risk of adverse CV events. Now again, this does not apply to the US. It's not approved in this setting. The 10th frequently asked question. What are the options for and role of triple oral antithrombotic therapy, or TOAT? TOAT includes an anticoagulant agent in addition to dual antiplatelet therapy. None of the available studies have included patients who have been on prasugrel or ticagrelor. So the need for anticoagulation needs to be assessed. With prosthetic heart valves, it's going to be warfarin, and you're going to learn more about that from Dr. Geske in his prosthetic heart valve talk. With non-valvular atrial fibrillation, in addition to warfarin, we need to be cognizant of the DOACs. So in this setting, we have our patient who is on anticoagulation, and they've come with ACS, so they need something else. the balance of efficacy and safety with triple oral antithrombotic therapy is tipped towards excess bleeding. In fact, the initial observational data indicates that TOAT is associated with a 3-fold higher risk of major bleeding compared to DAPT alone. In terms of the consensus practice guidelines, we use risk scoring systems to assess risk of thrombotic events versus risk of bleeding. Now, you're all familiar with the CHADS-2 VASC and HAS-BLED scores, and they're initially designed for atrial fibrillation, but their utility can be extended to other comorbidities. We need to assess whether the patient has presented with stable disease on the one hand versus acute coronary syndrome on the other, and whether percutaneous intervention is performed. With regards to the practice guidelines, in patients with high risk of stroke and bleeding, so high risk of stroke and bleeding, and a low risk of stent thrombosis, a VKA antagonist, warfarin, plus clopidogrel may be a reasonable alternative to an initial brief period of TOAT. In patients who are at high risk of stent thrombosis and atherothrombotic disease, a period of TOAT is reasonable. So if you break down our patient who's presenting with ACS into 4 different categories, the first is a low CHADS-2 VASC score and a low HAS-BLED score. And they've come with ACS and they have an absolute indication for anticoagulation. If they can tolerate TOAT for 6 months, that'd be fine. After that, we can change to anticoagulation plus a single agent for 6 months. And thereafter, we need to decide the therapy, either anticoagulation monotherapy or anticoagulation with a single agent. And this is all just expert opinion. There's no data to really drive a specific protocol. The second situation is a low CHADS-2 VASC and a high bleeding risk. Again, we want to limit the duration of TOAT to either 4 weeks or anticoagulation and clopidogrel for 4 weeks based on the WOST data. Thereafter, anticoagulation and a single agent. What if you have a high CHADS-2 VASC score and a low HAS-BLED score? Again, the risk of thrombosis is deemed to be higher. We can try TOAT for 6 months, and then we need to decide whether it's TOAT or anticoagulation and clopidogrel for 6 months. Now, if you're in this category, you're really screwed. I mean, you really are. I don't know what to do, and again, it's going to be you just have to be very careful. They're at risk of thrombotic events, and they're at risk of bleeding. And unfortunately, I think we're seeing more and more of these patients in our practice. And we just have to be careful with them. And they need to be followed up very carefully once they make that transition from the inpatient setting to the outpatient setting. Overall, the usefulness of the DOACs in triple oral antithrombotic therapy is unknown. Now, we've been impressed with the evidence of improved safety and efficacy with the DOACs versus warfarin in other populations, and for this reason, currently there is great interest in these agents